Very interesting and very useful IC, because for all of us as good ophthalmologists, we are waiting for a day when we really are really comfortable advising multifocal, and we are very happy to see when someone is doing well with multifocal. And somehow, unfortunately, the percentage of multifocal practice in everyone's, percentage in our practice doesn't really go beyond two digit. And that's very unfortunate. But believe me, there are practices where they have 30–40% of their practice is multifocal, and it's growing. Then what is the difference? So to explore that, we have this very important faculty that's gathered today who will touch on this topic which is very dear to our hearts. And to do that, we start with the first talk, and that's the role of technology for, where is it? The role of multifocal in current cataract practice. Dr. V.C. Mehta. Dr. V.C. Mehta is the director of Mehta Eye Clinic, and he's a prolific surgeon with a fair share of multifocals in his practice. V.C.
Thank you, Suhas, and good afternoon, friends. We are going to talk about the role of multifocal IOL in current cataract practice. I am from old school of thoughts. I have started doing intracapsular and then have now started doing the flex. So in those intracapsular days, there was a book by Norman Jaffe, and that book was titled Complications in Cataract Surgery, and the first sentence in that was that aphakia is the first complication of cataract surgery. How true it was. And now the intraocular lenses have come, and we can very well say that loss of accommodation is the first complication of IOL surgery if your IOL is not a multifocal IOL. And mind you, you know this, most of the patients expect that they will be able to read without glasses, and when they cannot, they will come and complain back to you. And I learned this very angrily from my patient. This is my first bifocal implantation, somewhere done between 98 and 2000. I don't remember the exact date. A young lady, pre-presbyopic age group, cannot read properly. She is appearing for some exam which will take her from help her migrate to Canada, and she could not read properly, so she came to me. Phaco was in the initial phases, so she was worried how fast I can get back to reading. And I said, well, there is Phaco, it will be so good, it will be painless, sutureless, etc., etc. And I did the surgery, and next day I expected the patient to be very happy, but the patient was very angry. And the patient said that, what is your all technology about? I could read before my surgery, today I cannot read anything at all. I said, you take glasses. He said, I don't want glasses. So that was a time when the pharmacia bifocal had hit the market, and I said, look, there is a new lens, I have no experience, but I am willing to put it if you say yes. So we put the pharmacia bifocal PMMA IOL, and that lady is doing so well. Even today when she comes back from Canada, she pays a visit to me. So the point is that there has always been a demand from the patient side to be able to see, read, and do everything without the glasses. Now, since my first bifocal IOL implant, I have implanted many of the multifocal lenses, but many things have changed. And a lot of things have changed in a cataract surgery, and the changes are that patient themselves have changed. Instead of being submissive, we now have some demanding patients. The technology of removal of cataract has changed. Our power estimation has changed. Newer multifocal IOLs, etc. So today's cataract patient is very active. You can't call them old because they want to do every activity they can, and they take up new activities and want to do them after the cataract surgery without the help of glasses. They are well educated because of the internet, and there is something called the new vision that they want, and that's an intermediate vision. For example, take a myopic patient. He or she would be expected to read without glasses after the surgery. Imagine that's the only vision that the myopic patient has, and you take away that from the patient and the patient is going to be unhappy. Or a young patient who has never experienced presbyopia is going to be unhappy with the monofocal IOL. And hyperopics who find it difficult to tolerate the glasses or thick glasses, they would be very happy if you put in a multifocal lens. So anything that they can lay their hands on, they want to do without the glasses. And there's a new distance, the intermediate distance. The computer, the tab, etc. So we have a new challenge to satisfy the needs of this new distance that has come into the play. Like it or no, most of us end up using either the tab or a laptop or a mobile phone, and that's what we need to kind of cater to in our cataract patients. Well, there have been advances in cataract removal technology. A lot of things have come. The best thing is that we are now quite sure to give a very a good kind of a cataract removal without significant collateral damage. What that means is that we can now kind of predict the outcome on our day one also. The best thing is that the new technology for IOL power calculation. The IOL power calculation has been the most important area where we kind of lack. And the newer step source OCT that has recently come and the formulas that have come now inches our emmetropia target close to 100%. We all know by this time that in a multifocal IOL, if you leave the patient with a little bit of astigmatism, the patient is going to be very unhappy. And we now know that addressing astigmatism is very critical, especially when you are working or when you are implanting a multifocal IOL. And there are lots of strategies that are available to us to address small degrees, moderate degrees, or large degrees of astigmatism, like a toric multifocal IOL or LRI with either the blade or with the femtosecond. Now there are newer IOLs. So these newer IOLs allows you to cater to the specific needs that your patient has. Suppose a patient is an avid reader, then you would probably choose a bifocal IOL which gives a crisp near vision. Or a patient is mainly sitting on a computer, then you can give them an extended depth of focus IOLs which will give them a good intermediate vision. So multiple options are available to satisfy the visual needs at various distances. Well, the diagnostics have changed very drastically because the expectation out of the surgery is so very high. We need to do everything to kind of find out the comorbidity, and we have at your disposal all the instruments that you can work with to find out the comorbidity. What has all this done? What it has done is that we are now inching closer to the outcomes of LASIK, and we are now coming closer to the LASIK outcomes in terms of refractive outcomes. In my personal experience, this is data of about 25 first trifocals that I have used. 80% of them have reached 0.63 and 92% of them have reached N6. So this is one of the kind of a best multifocal I have ever worked with so far till today. So in summary, the demand is there for a specs-free vision, the advanced removal, cataract removal technology, the advanced diagnostics, and the different types of IOLs. We need to kind of mix and match all of them to give our cataract patient a spectacle independence. So this course, I suppose, will probably give you an idea of how to integrate all this and give your patient a spectacle independence. So a lot of people like you are looking at using the trifocals or the extended depth of focus IOLs in near future, and I am very sure this course will help you to decide what to use in which patient and how to go about doing it. Thank you very much.
Thank you, VC. That was a good beginning for this presbyopia correction course. Now there's a slight change in the order. Since Dr. Tanvi has to catch a flight, she requested for an early talk, Sandeep. So she will speak on counseling the patient for multifocal. In fact, I presume in this whole gamut, if there's one section which really needs to be done well for the popularity and success of this presbyopia correction lenses, it is counseling. So I'm sure this is an important talk. Tanvi?
Thank you, sir. Good afternoon, ladies and gentlemen. Today my topic is counseling patients for presbyopia correcting IOLs, our very well-known multifocals and trifocals. So we know achieving spectacle independence is challenging. One would expect that with the combination of advanced diagnostics, the newer technology of IOLs, the better IOL calculating formulae and the advanced surgery, one would result in a very happy patient. But sometimes that isn't so. Today we will talk about counseling patients who have been selected. And how do we select such patients? So basically these are patients who have been examined and are anatomically suitable. There are also, these also include a subset which are the patients in the gray zone due to their inherent anatomic variations. For example, they may have a large pupil size, a large angle kappa, or they may have significant astigmatism. Then, of course, there are patients who are not suitable for the multifocal IOL implantation. There are many more to this list, but I have enumerated some of the glaring ones. So these are the patients who are an absolute no-no, and if you want a piece of your mind, then don't implant a multifocal IOL in them. They should be offered an option of a monofocal implantation. So now let's look at the patients who can be a potentially happy one. There are certain characteristics which should be looked at before determining, and this list will help you. A detailed discussion about his temperament is, you can judge him yourself. Is he a perfectionist? Does he come across as a type A person? A detailed discussion about the lifestyle choices and the needs should be done. Get to know his profession. Does it entail a lot of near work, computer work, or maybe field work? What are his hobbies? Does he drive at night? It is very important to judge the visual expectations of the patient, and if unrealistic, it is better to clarify it right then and there. The anatomical aspects of the eye which needs to be looked at before implanting the lens are angle kappa. As we said, if it is large, it has a tendency to cause a reduction in the contrast sensitivity post-surgery. This should be explained. A large pupil size, it will cause increase in the symptoms of halos and glare post-operatively and a reduced vision. And of course, the significant astigmatism should be noted whether it can be corrected by a multifocal IOL or not. Another key issue to address is, of course, the lifestyle needs. This should be looked at in detail. Talk to him about his vision-related day-to-day activities. You can also ask him, is he comfortable wearing glasses? How much reading does he do in the day? So all of these will give you a fair idea how he would cope post-surgery. Very important to see is the vision expectation. Let me explain this by giving two examples. We had a 24-year-old myopic patient who came to us with a posterior polar cataract and a best corrected visual acuity of 6/6. Now his primary complaint was that he didn't wish to wear glasses or contact lenses while playing. He was a professional player. He also gave a complaint of having glare while playing in the night because of the floodlights that were on the stadium. So now he wishes to get rid of his glasses. So we are presented with three options here. One, if we want to take into consideration the PPC and we think about taking off his cataract, we can implant a multifocal IOL in him, which will give him a decent vision for distance and near, both during day and night. But the complaint of glare, which is significant for him, will still be there after a multifocal IOL, so maybe this may not be the best bet. The second would be to implant a monofocal IOL in this patient. He will get excellent vision for distance during the day. He will play very well, but of course he will have to wear glasses for near. So the third option in this patient would be a corneal refractive surgery, maybe a LASIK or SMILE, which will give him a good distance vision the glare which he still has, but probably he's used to it, will remain, and it will maintain his natural lens in the eye. So for this patient, a multifocal IOL implant would not be the first choice. Versus a 62-year-old hyperopic patient who came to us with early cataract. We will look at his personality a bit. He is irregular with his spectacle wear. He wears it on and off. He is not keen on wearing glasses, because of which he has come to us for second opinion. He wants to get rid of his glasses also along with the cataract surgery. The best thing that we noted is that when he came to us, his prescription had changed pretty significantly, but he didn't seem to notice that. So for us, this is an ideal patient to operate on. Hence, it is important to discuss the patient's expectations preoperatively, and the reality of different needs to be addressed right then and there. Now, we know that we should explain these expectations and realities. These points you can cover with the patient. Most IOLs give a good distance vision. Intermediate and near may vary, but gets better with time. The vision can fluctuate in the early post-operative period, but it does stabilize over a month or so. Vision may vary in dim illumination, and it is always better when the IOL is implanted binocularly. And eventually, if all of these problems occur, then neural adaptation takes over, and this will reduce eventually. So it is typically what would be your ideal patient? A hyperopic guy with a happy temperament who enjoys watching television, likes his outdoor activities, reads occasionally, should be preferred. And then the icing on the cake would be that he or she hasn't noticed the change in their spectacle prescription, as it really hasn't bothered them. So this is your ideal patient. So if this near perfect guy doesn't come to your clinic, it is better to clear a couple of things beforehand. You must explain to him the advantages and weaknesses of the lens, if the case permits. Then it is always better to undersell and over-deliver in such cases. An open dialogue definitely helps between the patient and the doctor. So the advantages of the lens is that it gives a spectacle dependence reduces. The pitfalls such as the glares, halos, rings around the light, reduced contrast in dark illumination should be informed if appropriate to the case. Now it shows that the patient, if all of these explanations don't make the patient understand what he really is going to go for, this IOL counselor tool is an excellent patient education software which can be downloaded online. You have to pay for it, of course, but it can show a preview of how the patient is when he has presbyopia, when he is normal, how he looks when he has cataract, and how he would look after a standard monofocal IOL implantation. His distance gets corrected, not his near, and how after a multifocal IOL implantation where both distance and near can be shown clearly. Now this is about a man driving. Similar examples of a man playing or a patient doing his other day-to-day activities are also there on this website. Now essentially your counseling skills are going to be put to test by 3 types of patients. These are first 2 who are suitable for the multifocal IOL implant, but the first is unable to understand the pros and cons of the lens correctly even after you have explained, and second is having a financial problem, of course. Now both, if counseled properly and maybe with a little help from you towards the financial side, can be converted into potentially happy patient. Excuse me. This is the 3rd type of patient who understands the benefits and the possible disadvantages of the lens, but he or she is very happy with the glasses. I don't think you should push too hard for multifocal in these patients. Let them go. So to summarize, the best way to avoid drama is a good patient selection, as we have seen. It is more an art than science, and most times the experience and the surgeon's judgment works best. So the counseling should definitely touch on the points of possible optical aberrations, the neuroadaptation, the enhancement, and a talk on resurgery should be mentioned beforehand, with either a piggyback or a corneal refractive surgery, as the case may be. This can reduce a lot of aggravation post-operatively, should be spoken before. Enhancements should be spoken, as we just said. Inherent risks of the surgery and an IOL exchange in case can be told to the patient. In the end, I would say be confident in your decision, and if you know that the lens works well in your hand, go for it. Undecidedness equals poor conversion rates, so be confident. And spending more time preoperatively definitely will lead to a lesser time spent with the patient post-operatively. Thank you very much.
Thank you. Thank you, Tanvi. Now I invite our next speaker, Dr. Sandeep Nagvekar.
Yeah. Thank you for this opportunity, Suhas.
Sandeep, he's going to touch on a very important topic, because today cataract surgery takes lesser time than the amount of time that is spent selecting a patient as appropriate or not appropriate for any of these premium lenses. So, Sandeep.
Yeah, thank you, Suhas. So we all know that success in presbyopia correction depends on a proper case selection and accurate IOL power estimation and perfect surgical execution. So amongst these three modalities, the first two modalities can be addressed with technology. And in the very few brief 8 minutes that I have, I need to touch upon 4 of them. Optical biometry, we all agree amongst us in the audience that this is probably the way to go when you're handling refractive cataract surgery. And they are based on the principles of partial coherence interferometry, or OCLR, or sweep source OCT, as in the IOL Master 700. They are far more accurate as compared to conventional ultrasound measurements of axial length, wherein the standard deviation of these new instruments has come down to as less as 0.01 mm, and a manual or autokeratometry values with a standard deviation of 0.1 diopter. So if you multiply these with the formula, there's hardly any change that can occur. So therefore, this is the way to go if you have to now take in a patient for a refractive cataract surgery. In addition to the case and the axial length, they also measure the anterior chamber depth, the lens thickness, and the wide to wide diameter. Now the anterior chamber depth, the lens thickness, and the wide to wide diameter are useful in the 4th and 5th generation formulas because they help us to predict the effective lens position more accurately. How often we have seen that there are patients who are high myopes but who have a small anterior segment, and conversely, patients who are hyperopes but have a large anterior segment. By having the ACD and the lens thickness, you can predict the sagittal depth. With the wide to wide, you know how it flares out. So you can predict your effective lens position more accurately. So if you want to cover all axial lens and all keratometry values, it is better to go in for an optical biometry. And also, the wide to wide is helpful in approximately estimating the angle kappa. Tanvi just touched upon it. So if I have an angle kappa less than or greater than 0.4, I would not like to take this patient for a multifocal IOL because the quality of vision will not be that good. Which formula will I choose? The formula I'll choose will depend upon the measured axial length, and you can see over here on the screen all the formulas put here on the side. Holiday 1 works well for normal eyes as well as for most long eyes, and in fact all long eyes if you put in an adjustment for the measured axial length. The offer Q is better for the shorter eyes as well as some of the normal eyes. The SRKT works for normal lens between 22 and 26 millimeters, and for the higher lens if you make the adjustments. Hages, if optimized, works across all formulas. So does Holiday 2. Unfortunately, is something that you pay for and is expensive. Olsen C is freely available on the LensStar. The Barrett 2, if you don't have it on your machine like the IOL Master 700, is easily accessible from the website at www.apjacrs.r. And Hill RBF is an evolving formula. And with its final adjustment in August 2017, it probably encompasses all the axial lens from the shortest to the longest. And this is the famous Paul Wang and Douglas Koch formula for adjusting axial length in eyes greater than 25.2. So if you have measured your axial length on the IOL Master, you can optimize your axial length by these multiplication factors that you see on the screen. And depending on the formula, you can choose that. So anytime you get an axial length greater than 25.2, make an adjustment if you're not using your Barrett formula. The Barrett's universal IOL formula is probably the most unique formula because it addresses axial lengths of all sizes and keratometry values from the shortest to the steepest. It makes an automatic adjustment for axial lengths which are greater than 25.2, and as a result of which it probably occupies pride of place in my clinic right now. Coming to the OCT, OCT has become one of the most important tools today whenever I have to plan a refractive cataract surgery. How easy it is to clinically miss a subtle epiretinal membrane which can, affect the quality of vision the patient is going to have. So it is a lifesaver, I would say, the OCT. Or to take this example of a patient, these are actual patients from my practice, had a tension of 14 and 15 millimeters in both eyes, and only an IOL Master was able to pick up a reduction in the inferior retinal rim and a lens notch, which was seen more later on. So if you have a patient of glaucoma, obviously because of the reduced contrast due to glaucoma and the reduced contrast introduced by the multifocal IOL, he's not an ideal candidate for a multifocal IOL. Or take this example of a subtle diabetic macular edema, which can easily be missed clinically, but which will be picked up by an OCT. Or a small macular hole like this with an operculum in the vitreous. Or a not so subtle PED, as noted on your left, but a subtle PED on the right can be easily missed, and which an OCT will be able to pick up. Corneal topography, it gives us a lot of information like spherical aberrations, whether cornea is prolate or oblate, its eccentricity, its Q value, but all that means nothing. I just want you to look at some of the Zernike polynomials and just remember one or two things. We don't need to know what they are also. The Z40 gives you the spherical aberration. If your spherical aberration is greater than 0.4, you are probably not likely to recommend a multifocal IOL. And just below that, you see the Z3 minus 1 and the Z3 1. The Z3 minus 1 is the vertical coma. Remember, if your vertical coma is greater than 0.35, he is not going to be an ideal candidate for a multifocal IOL. Take this example of a prolate cornea, quite a prolate cornea that you have out here. The Q value is minus 0.46. The spherical aberration is 0.380. Falls within our category. I'll take this patient for a multifocal IOL. But take this example of a patient who's got an oblate cornea, and you find his Q value is 0.14, greater than 0. Okay, and you see his spherical aberration, it is 1.179. And if you see his vertical coma, it's 0.933. Be careful, this is not a patient for a multifocal IOL. In general, if you're looking at Q values, if your Q value is less than minus 0.4 or greater than 0.0, don't take this candidate for a multifocal IOL. Role of tomographers cannot be overemphasized because they measure the posterior corneal astigmatism, but beware, even in the Barrett's toric calculator, the principal assumption is that the posterior corneal astigmatism is about 0.3 diopters, as you can see in this case. But oddly, you may get a case like I did last week, where the posterior corneal astigmatism was 0.5. Today, the Barrett's calculator allows you to input the actual measured posterior corneal astigmatism, or the 0.1 seen in this case. These slides are with the courtesy of Dr. Samresh Srivastava, who was happy to loan me. iTrace has also become an important part of our armamentarium. It measures not only the total corneal aberrations, but it also looks, because of the placido, at the corneal aberrations. So by a process of subtraction, you can get the internal aberrations within the eye. And this is an example of a lady, 47-year-old lawyer who wanted to drive at night, who had a very subtle cataract, okay? And we are not very sure whether this patient would be benefited with a multifocal IOL, till we saw that the spherical aberrations, which were, and most of the aberrations that you can see on the upper right, are the total corneal aberrations, the total ocular aberrations. The corneal aberrations were very few, and most of the aberrations were internal. So this patient could have been counseled for surgery. Or this patient who showed astigmatism on measurement, but he said that I don't wear cylindrical glasses. So why are you selling me this multifocal toric IOL? So to this patient we could show, or rather he showed, this is not my case, that the total aberrations were less, but the corneal aberrations were neutralized by the lenticular aberrations. So such a patient will benefit with a toric IOL, and as you can see post-operatively, right now again the corneal aberrations are neutralized by the toric IOL implanted in the eye, and the total ocular aberrations as seen on the upper right are less to 0. And this is how we can use technology to benefit our patients. Thank you so much for a patient hearing.
Thank you, Sandeep. That was very useful and a very exhaustive, although you required more time to cover your topic. Now I request Dr. Vijay to speak on evolving technology in multifocals.
Good afternoon, everyone. I'm going to speak on technology used in multifocal IOLs. So as you know, the challenges for multifocal IOLs include the need to work at various distances, which include distance, intermediate and near, as well as to overcome certain problems like halos and glare, which are an inherent part of the multifocal IOLs. Currently used multifocals are mainly based on the principle of diffraction. If we go through the principle of diffraction, when an incident light passes through a diffraction grating, around 40% of the light goes undeviated, which is mainly used for distance vision. Another 40% of the light undergoes a deviation by an angle theta, which is equal to the breadth of the diffraction grating. This is used for near vision. Subsequently, a small amount of light gets deviated by an angle, double the angle of first order diffraction, which is actually not used for an useful vision. So that way this is considered as lost energy. If you look at the ultrastructure of the diffraction grating, the grating has a breadth and the height. As you know, the step width decides the additional power of a multifocal IOL. The smaller the step, the higher the additional power. The larger the step, the smaller the additional power. And the step height decides the redistribution of the energy between distance and near. So if you have a tall diffraction grating, then more energy is distributed for near compared to the distance. Whereas as the height of the diffraction grating is reduced, more energy is distributed for distance compared to near. There are several strategies used to overcome the limitations of the multifocal IOL. These include change in the diffraction design, asphericity and achromaticity. Coming to the modification in the diffraction ring, the first one is the limiting the diffraction ring to the central optics of 4 to 4.5 millimeter, wherein the peripheral rim is used only for distance vision. This is a non-diffractive optics, hence there is a reduction in the night vision problems such as halos and glare. Second is apodization. Apodization is a method wherein we reduce the height of the diffraction gratings towards the periphery. So as we know, the step height decides the redistribution of energy between distance and near. So as we reduce the height of the diffraction grating in the periphery, the more energy is given to distance. So this reduces the distance vision problems associated with multifocal IOL. If you look at the graph, around 40% of the light is distributed to near and 40% to near when the pupil is 1 millimeter in size, and as it goes to 6 millimeter, around more than 80% of the light is distributed for distance. Again, reducing the near ad will give a good intermediate vision as well as it reduces the glare. This is what has been used in Restore 2.5 ad. Here the modification that has been done is the central optic is made refractive instead of diffractive, followed by a diffractive optics and then again a refractive optics in the periphery. So what the central most optic does is it allows 100% of the light to go for distance. So as a result, you have a good distance vision, and the number of rings are reduced from 9 to 7 in case of Restore 2.5 compared to Restore 3.0. So this improves the near intermediate vision. However, it comes at a cost of the near vision. If you look at the light distribution for a Restore plus 3 lens, around 40% of the light is dedicated for distance when the when the pupil size is 1 millimeter, which goes up to 80% as the pupil dilates to 6 mm, and near vision, for near it's again 40% and again it reduces as the pupil size increases. Whereas in Restore 2.5, more than 80% of the light is distributed for distance even when the pupil is small, and it increases as and it decreases to certain extent in a 2 millimeter zone. Again the light distribution for distance increases as the pupil size increases. So this is how the distance vision problems are taken care of in 2.5 edition, and as well as a good intermediate vision is given. But however, as I said, it comes with a little loss of near vision. Again, there are combination of two diffraction gratings with different step width can be utilized in case of a trifocal IOL. So like if you recollect, the width of the diffraction step decides the near ad. So the narrower the diffraction grating, higher the power. So if we combine two diffraction gratings, one for distance and near, the other grating for distance and intermediate, then you get a trifocal IOL which has focus for distance, near as well as intermediate. Again, coming to the orders of diffraction, as we know by the basic principle of diffraction, there are primarily two orders of diffraction. Zero order diffraction where the light goes undeviated, which is given for distance vision, and first order diffraction, which is actually dedicated for near vision. This constitutes nearly for 80 to 82% of the light. However, there are further orders of diffraction like second order diffraction, wherein the deviation is twice the near focus, and third order diffraction, and so on. But these energy are not used for the vision, hence it's considered as lost energy. This energy can to some extent can be utilized in a trifocal IOL. So this is how it is done, where in a trifocal IOL, the first diffraction structure gives a for a zero order diffraction is used for distance vision. First order gives a near add of plus 3.5, and second order gives a power of near add of 7 diopters, which is again not used. However, a second diffraction grating has a zero order diffraction again, which is used for far vision. First order diffraction, which has an add of 1.75 diopters, which is used for intermediate vision, and a second order diffraction, which gives a plus 3.5 near vision. So this actually augments the near vision in case of a trifocal IOL. So the loss of energy is reduced to 14% compared to 18 to 19% in case of a typical trifocal IOL. Coming to the convolution, this is a modification in the diffraction ridge design, wherein the smoothing of the profile is done. So this limits the halo perception. And the latest design is the Eschlet design, which is called enhanced depth of field strategy. Here, the energy is more energy is distributed for first order diffraction, and in addition, there is an elongated focus instead of 2 or 3 primary focus as in bifocal lenses or trifocal lenses. So this gives an extended vision. So this technology is used in Symphony. And the latest, which is yet to come to the market, is called Enlighten technology. Here, like instead of a typical trifocal technology, a quadrifocal technology is used, wherein the focus is for distance 120 centimeters, 60 centimeters, and 40 centimeters. However, that 120 centimeter focus energy is redistributed to the distance energy, hence the distance vision improves, at the same time giving a good intermediate and near vision. So to conclude, performance of multifocal IOLs have significantly improved with the advent of newer technology. Diffractive multifocals IOLs are here to stay with further refinement in technology. Thank you for your patient hearing.
Thank you, Dr. Shetty. We now invite Dr. Suhas to enlighten us on what type of lens to be chosen for your particular patient. So over to Suhas.
Good afternoon. Well, we are hearing about different technologies, but friends, I must tell you, every lens will work, but it will work if the surgeon has complete belief in this system of presbyopia correcting lenses. That means it translates into your body language, and I have seen it among all those who have used this lens and who continue to use extensively. A multifocal or a presbyopia correcting lens who works for them, who have total belief in, one, the technology working, number two, a strong belief in the neural adaptation that all of us have and we always underestimate. With this, when a patient comes to us, there are several available IOL options where we don't forget even the monofocal or the toric. And finally, of course, is a presbyopia correction can be done with a monovision also. And there are several of them who accidentally or planned do a monovision and it works for them. So talking about presbyopia correcting lenses, all right. Now, although we have covered it in a counseling session, before a patient comes to me, and when I have to decide, what lens I'm going to put, I have to definitely make sure that this patient is ideal. In a sense, I have to look at his personality. I have to look at corneal cylinder that he has. Would he be doing good with a multifocal? His current tolerance to glare is a big indicator in my choosing what type of lens I'm going to put for him among the presbyopia correcting lenses. And of course, his general knowledge, whether he has unilateral or bilateral cataract also helps me decide which multifocal I'm going to use. Obviously, we have had a nice talk on pre-op testing. Those go without saying that unless they give you an approval for a presbyopia correcting lens, you will not go into the next step. Pre-op counseling definitely is an important aspect. The chair time that you spend is going to matter. May still need low power glasses. Post-op is something that you have to convey. Counseling regarding glare and halos goes without saying, is something that has to be mentioned. Counseling regarding bilateral cataract in the close vicinity is an important factor. There are patients who would say, doctor, I do not want to get the other eye done now. Then either you change the type of multifocal you use for them, or you probably put it off for some more time. And of course, when you do it, you should also be talking about the reversalness of this technique. If the patient, in the rare circumstances, is not happy with this, but it normally doesn't happen because we definitely get used to it. Now, which IOL among the presbyopia correcting lenses that I will choose will depend on his needs. His needs for distance, intermediate and near. His profession makes a difference. His recreational activities, like the case that was mentioned in the counseling session. Now that was a patient, who definitely wanted to get rid of his glasses. I said, why? He said, I'm a footballer and I have to play in the night and under the glare, under the floodlight. And obviously we knew that probably he won't be a good. His amount of computer and mobile usage also decides which type of a lens probably would be better for him, because today we have wide variety of presbyopia correcting lenses, from a low ad to normal ad to high ad to, of course, the trifocals and extended depth of vision lenses. There will be some who will want extreme crisp vision for distance, and they are not so particular about near vision, but they still would want to be rid of glasses. Probably they go for another category. I think I have a wrong presentation. Another step that I would really like to concentrate on or look at is a multifocal lens which will use lesser light overall. The distance may or may not be as crisp as monofocal, average intermediate vision and excellent near vision. I'm sorry I gave them and they have put a wrong presentation. It doesn't matter. Another thing that I'll do is, before I tell, I would always show them, when I talk of glare and halos, sometimes they don't understand. It's always better to show them the pictorial thing, and also tell them that if their needs are something where a low ad is going to be more useful because he has a lot of outdoor activities, probably a low ad would be better than a high ad. There is there's another concept of a blended vision where low power near ad in the dominant eye and a high power in the non-dominant eye would also probably work. So the mix and match is another concept that works. And the new lens that gets added up is the extended depth of vision lens, which combines a diffractive pattern with an achromatic technology, and hence much lesser glare and halos as compared to conventional multifocal, because almost has it something like a monofocal, and contrast sensitivity is almost comparable. This is a picture I would always show to my patients before I decide, because when I have three types of lenses, it could be a conventional multifocal, it could be a trifocal, it could be a symphony, but I have to show them, to tell them that symphony or the presbyopia correcting lens, like an extended depth, has contrast or the halos which is almost comparable to a monofocal. No, you know, it's totally a different presentation. Yeah, you know, when a patient comes to me and if I have to finally decide what IOL I'm going to use, if a patient is someone, you know, whose needs are, let's say, he has to work on the computers, he has to all the time, you know, he also is very particular about his near needs, or he wants to drive and all that, then I would kind of settle for a trifocal lens with that supposed to, or that is what we all have experienced, that really works well. Someone, you know, who just wants to get rid of glasses, whose needs are not so very accurate, but he definitely, like a retired person who wants good reading vision, wants to watch TV well, he probably, you know, settles for a multifocal. Someone, you know, like who wants a good vision, who's very acutely aware of the contrast, and or he says, I don't want, you know, those problems at night. So he would probably go in for, in my practice, extended depth of vision lens, where I tell them, look, this lens will overall give you a good vision, but an occasional need to wear low ads is not ruled out, and probably that lens would work for him. Then of course, someone says, doctor, I want to get one eye done today, and for the another eye, I want to wait for a while. After explaining to him that, look, you will have to go in for both eyes if you want multifocal, still he doesn't want, I'll be more inclined to put extended depth of vision kind of a lens, but that lens in my experience has really worked well when I do it today and I put off the other eye for some time. And of course, the blended vision or the mix and match is something that I will always look at. There are people who in the past have used contact lenses or monovision with spectacles, and they know this concept, so they would probably be good for low ad and high ad as a combination. And of course, there are cases where it could be controversial, but if a patient needs an IOL exchange and he still wants to have some presbyopia correct, some near vision, I would be a little more inclined to use extended depth of vision lens in such an eye. But all in all, what I want to say is any biological process is not a perfect one. So I have to explain to him, and I'll definitely do it. But one thing is certain, I'll talk to them about the halos and glare being part of the procedure. But one thing I'll definitely tell them, look, whatever good vision that you get is going to be in the good light. In the evening, your vision is going to have these problems, and the glare problem is something you are definitely going to overcome. And when you're so confident about these things, when you get across to him, they probably would agree. But one thing is certain, that it all depends on what exactly he wants. If he says, I'm absolutely okay using glasses, probably he is not a candidate for multifocal. But if someone is very keen and he accepts all these drawbacks, I think I have a candidate in whom I can definitely put it, and he should really do well. With this, sorry, I didn't look at that. So patient needs to understand that there's no return to vision of 20s. Visual performance depends on light conditions. Neuroadaptation takes 2 weeks to 2 months or sometimes more, and there'll always be an impact on quality of vision at night. So this is something that I'll literally, get into their mind, and then of course they are great candidates for multifocal. And in spite of all this, and one thing I have seen that practically all the lenses work. Some lenses work better, but they just go with what kind of an expectation that patient has. Thank you so much.
So we all agree that some of our patients are going to be unhappy after this procedure. And who better than Dr. Vasavada to tell us how to manage this unhappy patient after a multifocal IOL implant? Over to you, sir.
Yeah, thank you, Sandeep, for kind words. I do receive research grant support from Alcon Laboratories, but has no financial interest in this patient's. Can I move to the next one, please? Right. I think this is very important, and all the experts already have given a lot of tips how you reduce that. But before I talk, I just want you to put this slide here, and please read this article which was published in 2014 by the Cataract Clinical Committee members at that time on indications and contraindications of multifocal IOLs, and you will be able to reduce that. This is not working here. The mouse is not working here. Can I go on the other side? The mouse. It's not moving forward. Which one? How do I move forward? Forward. This one. This one. Forward? I want to move forward. I don't want the light. All right, I'll do that. I think first of all, when the patient comes, and your assistant will tell you, this patient is waiting there and he's the next one to come, be prepared. He's very, not happy. Our staff knows that this patient is not very unhappy. So understand the reason first when he comes, and whatever the reason, please and please repeat several examinations. Some of this you already have done it. You look them carefully every time, even if you know you're not going to say anything more. Keep doing all this examination and see with different angles, different technology, and if you don't have it, send it. I'll get this new scanning technique or imaging. But whatever, please look for the following common reasons. Number one, in my experience, is the residual refractive error ametropia or residual astigmatism, and I keep doing this from time and time. I'm not improving terribly well on that, I must say. So that's the commonest reason in my experience. Second is the meibomian dysfunction, the tear film, and some parts of our country you will have more than others. Slightest opacification, like high myope, bothers the patients with same degree of PCO in myopes or these multifocal would bother them more compared to the healthy retina and monofocal. Third is the IOL centration, and that some bags are not compatible, and some lenses designs are that they don't remain centered after a period of time. And then the macular functions, and finally, there are personalities will never understand neuroadaptation. This is an executive typical example, wanted to get rid of glasses. So when I said Restore Plus 3, this is a representative of a traditional multifocal, and that's what I'm going to talk today on the unhappy patients, on traditional Suhas and other sales shade. What are the other solutions? So patient is upset that I still have to need glasses. What are you saying? I thought, I paid this much in multifocal. What is it? And I can't see that well at distances anywhere. Whatever you say, his unaided is 6.9 and N8, and best corrected is 0.5 sphere with 0.75 cylinder. And that's what is we want to understand, that residual ametropia. So we learned that residual ametropia, refractive error, is the most common cause of the dissatisfaction of the patients. Now, preoperative expectation management, and he would expect that because I'm putting this IOL which is designed to remove the handicap, why should I wear the glasses? So we must try right before he even considers multifocal that we can only try, and honestly, majority of the patients would need to wear glasses for some activities. If you are doing 10 activities, 1 or 2 activities would need to improve the quality of vision and things like that. So you must tell them and tailor and make him realistically expectations. So we are not finally, you know, we don't have everything in our hand, and there's nothing like zero. Or doctor, I've been to the other colleague and he said, you put toric lens and still there is this much of astigmatism or this much. Your surgery, the calculations are wrong. Tell them that if you measure these objectively, you will find some, but generally most of the patients don't need to wear that little small degree of refractive error. So tell all this in the counseling. 68-year-old financial expert with same situation, same traditional multifocal. Well, I can see, but it's not very crisp. And the Economic Times, oh my God, this is my, I don't know whether you know it, but all the newspapers are in a white paper. For some reason, Economic Times comes in a yellowish tint. And even with the most healthiest, they won't find it easy to read. And this is the guy who would read Economic Times and no other magazine. So it's okay, but it really needs an extra illumination. So, but I can't go with headlamp on my forehead. You say extra, I can control in my office, but I'm a marketing, I have to go and visit so many people. So tell them that you will have a reduced contrast sensitivity. What does it mean? It means many things, including what you're saying. So bring it to the notice. And this is the slide I borrowed from late forgot, the great American teacher who just recently passed away, Roger Steinert. Roger gave me the slides many years ago. This is the contact lens literature, but it describes so well. On the up left is the sharp blur and illuminance. That's what happens when you add and defocus 1, 2, and 3 diopter to your image, and that's exactly will happen on your traditional multifocal, and you can understand that can never be that sharp or blur, and that's the reason the vision is not crisp if you're really very fastidious. So give them a predictive instruction, forthright, that you will have a new reading distance. You may be myopic and you think it's my birthright to read this one, and you need extra illumination, whatever the thing is, and do not look for problems. Why? Because, doctor, when I look to the bulb, I see the halo. Did you look at that bulb ever before you had in your life? Why now that post-operatively you want to look at the bulb? They never looked at the light earlier. Now you want to test everything. They want to test every aspect of what you did because they paid quite a bit. Post-diffractive implantation complaints. Sometimes I see clear, sometimes I don't, and that's where you want to see it's fluctuating. And the common sense would be to see the environment, and tear film instability is a very, very, very important cause of that. And this is another one. A singer, a professional person, I can't face the lights from the stage anymore. And when he's on the stage or a podium, that's why I didn't have a multifocal, but I asked him to shut the lights when I came here. But I'm okay, I'm still a normal lens. Multifocal IOLs lead to glare and health, and Suhas said that. So forthright discussion on the precision and flexibility. You can't have stars and moons, you will have to pay the price. And this is once again an engineer. It's not very crisp vision, good unaided 6, and 6. So that's where my colleague Samresh taught me the value of aberrations and to determine that preoperatively optical profile and the axis and sort of thing. And if there is a disparity between the visual axis and the center of the optic or the pupil, you will have lots of problems, and as this patient has. So in simple words, if the angle alpha is more than 4 or 4.5, do not consider multifocal lens, generally speaking. So when the patient comes, always listen and ask them again. If they've forgotten to complain, do you get that also? You don't get that. Oh, it's good, because sometimes you get that also. So ask them, make sure that you have asked him and drained him of his all that and reassure him. And there is a very nice article, if you want to understand neurosensory adaptation with the contrast imaging, they will show you immediate adaptation, and then the gradual brain adjustment will take 6 months. So wait for 6 months before you consider, and do not shy away from that, and always learn from the fellow eye. And this is the final slide. I somehow have not been able to, I've not done explant, but I have many patients who could have been explanted. taking time, and if your patient is a long-standing patient, he trusts you and believes you, and you say, I'm sorry that it didn't work out because the biometric measurement machinery is not that precise. We thought you will be, but this is one of those things. I can do that, but I would suggest it needs second operation, and this little glasses, you want glasses all the time, you wanted not to have, but I would think, consider, and most of the time, we are lucky that the patients are very kind to us. Not because that we are more experienced how to handle this, but the patients are very kind to us and they forgive us. So thank you so very much.
Thank you, Abhay. Now I request Dr. Charles to come over and give his keynote address.
Thank you very much indeed to the Society. Ladies and gentlemen, it's an honor to be invited to address you. This lecture is going to be completely the reverse of the previous lecture, in as much as I'm only going to talk about one patient, and I'm not as clever as Dr. Vasavada. My slides come and go. They don't twirl about and dance, so I'm sorry if you're disappointed. And it's still not advancing. There we go. So this is a single case report with some comments. So this was a man who came to see me because he wasn't happy with his presbyopia correction. He was 48 when he came to see me and a software developer for a bank. So high pressure, lots of money. And he had been a myope who had a LASIK in 2006 when he was 40. And I'm always a bit nervous about doing LASIK in people over 40. And I never do it over 45. And then, of course, he predictably became presbyopic, and somebody else did bilateral light-adjusted lenses with monovision when he was 47. A light-adjusted lens, in case people don't know, is a technology where you put in a monofocal lens, and you can use a laser to change the refraction once it's inside the eye. It's not very widely used, but it's quite clever. Somewhere along the line, he had an ALT for so-called normal tension glaucoma, although I couldn't really see why, but he was desperately unhappy with his anisometropia. He couldn't read comfortably, he couldn't use a VDU comfortably. So there were a number of things at this stage. First of all, the degree of pre-LASIK myopia was unknown. He hadn't got a clue. He was a vague historian. It had been done, I don't know where, but there was no hope of finding out. So that made life a little more difficult. Given that he'd had LASIK, I think a light adjustable lens was quite a clever idea, because we all know that biometry after LASIK is not that predictable, despite what people would like to tell you. And I think that it's also reasonable to offer monovision, but the trouble is this man had never had monovision before, and did not have a contact lens trial to simulate monovision before he had his surgery. So what was he like? Well, first of all, he was unusual in being left eye dominant. So if you're going to do monovision, please check which eye is the dominant eye. The surgeon who'd done it had noticed this, and that eye was 20/20 unaided with a trivial refractive error. The other eye had not bad unaided vision with about 1¼ diopter of myopia, and binocularly he was 20/20 and J3 unaided, which you'd think most people would be happy with, wouldn't you? So he wasn't happy, and I just wondered what my options were. And I think one of the things that we are losing is the idea that if you've got a difficult patient, talk to your friends about it. Just sound out what they would do. And you know what everybody told me? Everybody said, don't do anything. So what did I do? Well, I looked at the options, and the first one was to do nothing, and he was adamant that this was unacceptable. I told him get some spectacles, and he said, no, I'm not doing that. You could do an intraocular exchange for a multifocal lens in both eyes. Now the problem is, how do you know your biometry is going to be right? I don't. I think that there is always a chance of doing a lens exchange after more than a year that you may damage the capsular apparatus to an extent that fixation becomes a significant problem, and trying to put a multifocal lens not in the bag, you really do get into quite unhappy territory. And then there was the opportunity of a secondary duet conversion. Now, what does that mean? Secondary means that it's a second operation, obviously. A duet means that there's a second lens in the eye. This is not a piggyback lens. Piggyback lenses were designed to go in the capsular bag. Duet procedures are done with lenses that have a platform that is designed to go in the ciliary sulcus. And the conversion is because I was converting him from monofocal vision to multifocal vision. So I spent not quite hours, but a lot of time talking to him, and I got a detailed informed consent that went to several pages. I did YAG laser iridotomies because it helps me sleep at night to know they're not going to get pupil block glaucoma. And then he had immediate, sequential, bilateral, secondary, duet conversion procedures in March 2016. The right eye needed a spherical and toric multifocal correction, and the left eye just had a plano multifocal. And these were 5-minute operations. It's really, really easy, really low risk. These are the lenses. So that's the multifocal, and you can see it goes into the ciliary sulcus. It's very soft, and these little notches help it not to rotate, and that's important with these ones which have a toric marker. So it took a bit of time to settle down, but 3 months later, his unaided vision was 20/25, 20/20, and his unaided near vision for each eye was J2, and he's a man of few words. He says, eyes are good. So, what are the learning things from here? First of all, don't create surgical monovision without a monovision contact lens trial in a refractive patient, unless they're contact lens wearers and are already used to monovision. And if you ever do monovision, please double check which eye is the dominant eye, because there are left eye dominant patients. And the second thing is why I think I was invited to contribute to this particular session is that supplemental intraocular lenses are a useful tool for refractive problems. And I've got a minute left, and I wonder if I can just take you to the next level. I haven't got a slide, so you're going to have to listen a bit carefully here. What about a patient who's been to see one of my esteemed colleagues in Ahmedabad, for example, and he's listened, and he said, well, I really would like not to have glasses, but I don't know about this glare and halos, and everybody says it's risky to exchange lenses, but, there must be something better. And the answer is, you can do a primary duet prelex. So you put a monofocal lens in the capsular bag, you put a multifocal duet in the sulcus, so they have multifocal vision, and you leave them, well, I like to leave them 6 months to neuroadapt, but if the patient is desperately unhappy, you can deconvert them. It's not an explant really, because it's part of the planned procedure. You can deconvert them by just taking out the supplementary lens, and that again is a 5-minute procedure, extremely low risk. You dilate the pupil, you go in, you pull out the lens. So we now have reversible surgery for presbyopia, and people have the opportunity of trying multifocal vision, even if they think they're not quite sure they want to. Of course, they have to have quite deep pockets for all this surgery, but that's that. So, thank you very much, and I hope somebody's going to offer me some of that later on. Thank you for your attention.
Thank you, Charles, for a nice talk. Now we have some time. If there are any questions from the audience, we would certainly like to address them.
Sir, which angle is more important, kappa or alpha for multifocal?
What's that?
Angle kappa is the angle which you can measure. Angle alpha is the angle within the eye behind the lens in the vitreous, so it's not measured. Clinically, what you can measure is angle kappa, so it's always angle kappa. You're never actually measuring angle alpha.
Yeah, like you mentioned very correctly, angle kappa is extremely important to measure. The reason why the importance of angle alpha came in for multifocal lens implantation is that very often the patient's visual axis and the centration of the IOL. Now the IOL usually centers in the center of the capsular bag, which is usually the center of the limbus, and it may not always coincide with the patient's visual axis. So the angle between the patient's visual axis and the center of the eye itself is the angle alpha. Now why it is important, like was shown in the previous presentation, is that if your lens centers a little bit away from the place your visual axis is passing, the rays of light are actually going to pass through the rings of the multifocal IOL. So they may not affect the actual refractive outcome, but they may actually enhance or worsen the visual phenomenons of glare and halos. So for implanting multifocal lenses, more and more people are looking now at angle alpha, and if the patient has a high angle alpha, then probably they are more likely to be facing issues with glare and halos surrounding lights, and most people now believe that in any angle alpha around 0.4, 0.5, there is no actual study to prove a cutoff of say 0.4 is the limit or 0.5. But most surgeons now believe that any angle alpha more than 0.4 or 5, you need to be cautious in considering multifocal lenses.
Yeah, absolutely right. In fact, IOL manufacturers have also moved in that direction. If you see the central apodized zone in the +4, it used to be about 0.73. Then they increased it to 0.87, and now in the restored +2.5 adds the central zone is about 0.94. So there is very less chance of the first ring now directly bisecting the visual axis.
I think we make life so difficult for ourselves. With all these fancy designs, how high should the fringes be, what angle should the fringes be, and so forth and so forth. Nobody on the previous presbyopia session, on this one, has spoken about PCO. If we have PCO, we screw up the whole lens totally. What I like to see is a mathematical solution. So if you go back many, many years and look at the design of the intraocular lenses then, they were fairly simple. So what we are trying to do now is to play with mathematics and curves. Nothing else. No fringes, a straightforward monofocal within situation marked lens, but with aspheric eccentric curvatures on both front and back surface. How does that solve the problem? Very easily, because we are increasing the depth of vision or the depth of focus. And I am a firm believer this is the only way to go. Then we get rid of the halos and we get rid of the glare. Thank you.
Well, as long as the macula is not involved, ideally it shouldn't matter. But if he is extensively lasered, his peripheral vision as it is goes down a bit. So probably it'll depend on how bad is the diabetes. If it's not an extensive one, a routine, well-controlled diabetes, probably he should be okay for multifocal, as far as I think.
I think, thank you for bringing this up. This comes down to this contrast sensitivity issues and other things. I just learned from Dr. Jack Holliday other day that even in the best alignment with all this angle alpha, everything optically perfect, maximum light energy would be going around 82% or so. And then you will have residual ametropia, then you will have some decentration, then you will have macular pathology. So in reality, on an average, multifocal patients will have about 65% of the light energy going. And that's the problem. That's why the low ads multifocal has some respite. And the glorious example of low ads is Symphony and plus 2.5. Both are low ads. Symphony is 1.75 ad, and this one is 2.5. And Oculentis has 1.25 and options for. All of the low ads, as Suhas and others have said, gives a very good quality distance vision, but then a lot of light for reading and a lot of reading aids. So there is no solution. The trifocal and PanOptics and Zeiss and others are addressing that, but they've improved only a little bit. All the negative of this multifocality still persists. So I think we still have a long way to go to satisfy a patient who is asking at the moment to what we feel like stars and moons. So this is a reality. So thank you for bringing this up, very simple basic concepts.
Yeah, the question is the experience of Zeiss trifocal. Am I correct? Yeah. Okay. Why I am answering the question is because I have an experience of around 250 Zeiss trifocal IOLs. Since last 2 years, I have given up all other multifocals and I have started implanting only this, because for the first time I realized that the distant vision as well as the near vision is extremely very good in Zeiss trifocal compared to any other multifocal that I had ever used in the past. So one must remember that the degradation of the distant vision is a major issue in a multifocal IOL. You may get a near vision, but the distant vision is usually not touching 6 by 6. It's around 6'9", 6'9" part. So this is the only IOL which is able to give, considering that your patient has passed through all the pre-operative workup that you are supposed to do, and you have chosen the patient for a multifocal implantation. My choice today is a Zeiss trifocal IOL. Yeah, please.
Newly started using multifocals. After getting encouraging results for the first 2 cases, when I did my 3rd case, while injecting, little bit small portion of the trilling haptic got cut. I thought it will center. I could have removed it then and there, but maybe I had to extend the wound. I placed the IOL. Next day, IOL was decentered. I couldn't keep it like that. I convinced the patient. I had to extend the wound. I removed that and I placed the same multifocal, the different lens, same design again. Now, lens is very well centered, but patient has cylinder of 2. Now what should I do? Shall I do PRK, or can a simple LRI would suffice?
Well, 2 diopter of astigmatism is possibly too high for an LRI to correct. My choice would be to go for your either LASIK or a surface ablation with the excimer laser.
Can this Sulcoflex would be a good idea?
Well, Sulcoflex toric lens, the only experience that I have, did work very well for 6 months, and one fine day decided to rotate. So rotation of a Sulcoflex IOL is a reality, and I think the better idea is to do a LASIK or a surface ablation, whatever is your choice.
I think that's true, but before you go down to the surgical options, please investigate with aberration corneal profile, the retina once again, and wait for a while. I would not jump into the surgery 2nd day or 3rd day of the decentration. Just wait, because you heard the blood aqueous barriers in the previous session from Lisa's group. I think you don't need to jump, and I also have some other opinion than Suhas on the 2nd eye that many patients in Indian culture don't want very soon. And depending on the person, but you don't need to do second eye as early as the Americans have taught us, and the industry is pushing this up. To be honest, you can wait in a selected manner, and I do wait, actually. I said, you already had spent this much and only had that. Why are you in a hurry? Just wait for everything to settle down and come down. So you can work this in either way, whatever you want. So I would have waited and then do all the detailed investigation. And these options are very valid.
Can I convince her for the time being for glasses, I mean,
Sure,
optical
absolutely.
correction?
Yeah, absolutely. You need to, that's where the talking are, and these on my left side are the experts. Ask them after the meeting is over. They will tell you how to talk to them.
Thank you, sir.
I will give you another piece of advice. Why don't you give this guy a mix of artificial tears? You put in a low concentration, a microdosage of either pilocarpine or carbachol, about 0.03, 0.04%, and then you don't need to do nothing, and the patient will be very, very happy.
So just I don't know if it is justified, but if any of you all do develop cataract, which lens would you probably choose for yourself for presbyopic correction?
For me, it's too early to think, actually. So when time comes, I'll let you know. I think all of these guys have a tremendous experience of multifocal and toric and blending and whatever you heard. Yeah, sure. Yes, sir.
I've done quite a few extended depth of focus lenses, mainly the Symphony, and I find that it's quite a forgiving lens. Even if there is a slight decentration, patients are quite happy, they don't have any complaints. But one particular case I'd like to share with you, both eyes, close friend of mine, very good surgery, well-centered lenses, 6'6", N6 without glasses, but he's a very unhappy person. And he says, whenever I go into a room, I can't see anything at all. Into a room, whenever he enters a room, he says, I just can't see anything, who's sitting, what's happening, I just don't know. We tried everything, mainly lubricants, counseling, talking to him, asking him to take some time, but I find that he's very, very unhappy. Contrast sensitivity. Pilocarpine.
No, I think, no, contrast sensitivity.
I thought it was contrast sensitive, but what do I do now?
No, I think there's nothing you can do about it, but that's where the counseling is. And I had a similar experience when I did this low ad restore. So Symphony, the 2.5, and all the low ads behave exactly the same because basically they are optically only low ad. This is not a true extended depth of focus. That doesn't work. But all of these will need a lot of light, and that light also will depend on the age of the patient, the retinal health, and diabetes, and hypertension, and so on. So I think be careful. You must mention that you must have a light, and if you think you can't control it, I'm a marketing CEO, then you don't put it there. Because you put that, so all these things which have been talked about is very good.
Well, thank you. We have the last query because I'm repeatedly getting reminders that the time is up.
Oh, sorry to hold you up. What are your thoughts on using multifocals in one-eyed patients?
One-eyed patients. Well, I think, Ranjit, if you properly counsel the patient and explain to him all the limitations that this technology has, most of the time, if I've ever implanted a multifocal in a one-eyed patient, and I've done it in 4 of them, it's always when they have insisted. I have never offered it as my primary choice. But if the patient evinces a very keen interest to do that, then why not? And I've found them happy most of the time because they understand the limitations of the technology. They accept that there are going to be issues. You have to tell them, first of all, you have to go to use more light, And of course, do all the other things like spherical aberration. This doc spoke about that bilateral symphony. I'm sure if he sees the cornea is going to high spherical aberrations, so the contrast sensitivity is going to be less. So if you do the workup properly, explain the patient and say despite all this, there's going to be, I think if it's a well done cataract surgery with a well placed intraocular lens, I think it can work, yes, of course.
Thank you so much. Thank you, everyone.